speaker is Dr. Mayuri Khamar. Dr. Mayuri Khamar is a well-known glaucoma expert and presently the Honorary Treasurer of the Glaucoma Society of India. Over to you.
My slides, please. Thank you, Chandrima, for giving me this opportunity. I will be talking on the new therapeutic timelines. Ever-rising demands of the glaucoma treatment results in a constant search of avenue to improve upon existing treatment and innovate a new option. This is the timeline I have shown. The pilocarpine was introduced in 1875, and then came the beta blocker after 100 years, and then the PG analog came after 25 years, and now, after 21 years without new drug class of drug, we have a new drug. This is the drugs that are available to us in India, and the new addition to that is the ROCK inhibitors. We know that the degeneration of trabecular meshwork outflow pathway causes the elevation of intraocular pressure, and that leads to the vision loss in glaucoma. And all the medicines that are available to us commonly uses this trabecular pathway, but do not target the diseased trabecular meshwork. So the new drugs, 2 molecules are now available. One is netosudil and ripasudil. These are ROCK inhibitors, and both FDA approved by US as well as India. And it has a novel approach to the IOP reduction. And latanoprostone, Bunod, not available in India, but available in the West. So I will be talking more on the ROCK inhibitor that is now there with us. So it reduces the cellular stiffness, and there is a norepinephrine transport inhibition. So these facilitate both trabecular as well as uvascleral outflow. And the unique part is once a daily dose, so it improves the compliance. The second one is the latanoprostone, which enhances the uvascleral outflow, but Bunod is a nitric oxide, and it dilates the blood vessel that improves the circulation of the eye. Now, ripasudil, it decreases the outflow resistance in the trabecular outflow pathway, and the average IOP reduction is 3.7 millimeter of mercury, while netosudil, there is also a reduction in the aqueous production, and the IOP average reduction is 5.5. The third molecule still in the lab, not available to us. Now, ROCK kinase increases the cellular contraction, extracellular matrix production, and thereby there is a resistance to the trabecular outflow. Now, being an inhibitor of ROCK kinase, netosudil lowers the intraocular pressure by 3 mechanisms. It relaxes the trabecular meshwork, thereby increase the outflow, lowers the episcleral venous pressure, and reduces the fluid production. It is very important to know that there may also be non-IOP independent benefit, like I will explain you this later. The neuroprotection of optic nerve, then improvement of the blood flow to the eye, and reduction of the oxidative damage to the trabecular meshwork. This all will be the addition to the IOP reduction. Now, we know that the higher the intraocular pressure, better is the IOP lowering, and that is true with the timolol, latanoprostone. This study has shown that the higher the intraocular pressure, more is the IOP reduction. But when netosudil was compared with the PG analog, it has been found that the netosudil produced the same IOP reduction regardless of the patient's baseline IOP. So that is something that would like to have, particularly with the normal tension glaucoma patients. As it reduces the episcleral venous pressure, which is essentially sets the floor on how low the eye pressure can go. And that's why it is a potential drug for treating the NTG patients. Now, how well it works, and when we compare this with the gold standard 2 drugs, timolol and the latanoprostone, it is equally effective. But one should remember that it is not fast acting. It can take up to 6 weeks to see the full IOP lowering effect. So don't switch this drug to the other molecule if IOP reduction is not adequate. Just wait for some time. Now, chronic use of steroid can raise the intraocular pressure. The mechanism here is again the ROC activation at the trabecular meshwork. So being an inhibitor, this drug could potentially prevent or limit the steroid-induced elevation of intraocular pressure. So that's why it can be used when patient is on steroid post-operatively or for some other thing. Then you can use this drug for IOP lowering. Now the side effects are 50% of my patients, they do feel that there is a conjunctival hyperemia, red eye problem. Then the conjunctival hemorrhage, small bleeds on the surface, corneal versillata is also a problem. But these versillata is reversible and it is not giving any visual disturbances. The associated epithelial keratopathy is also been noticed with this, and it should not be given to the unhealthy conjunctiva. So how to minimize the hyperemia problem? So I ask my patient to use this drug at evening time or at night time so that there is less hyperemia visible on the daytime. The latanoprost, I will not go into the detail as we are running short of time, once a daily. And it has two moieties, the PG analog as well as bunod, which is a nitric oxide, and it widens the intracellular spaces in the trabecular meshwork. It is as effective as the PG analog, latanoprost, but it decreases 1.2 millimeter of mercury of additional IOP lowering compared to the latanoprost. Safety and tolerability is same as the PGs. And it can be used as a, now the combination of the nitazoxanide and latanoprost is also available, rocklatan, once a daily dose. But it is very expensive and not available to us. Last few slides, innovation can be there in the drug delivery system, and this is already been explained by the Raju in the previous talk, Rajul. The injections are available, which are subconjunctival delivery system, biodegradable polymer particles are available, or intracameral injections are also available. And the punctal plugs, topical ophthalmic drug delivery system, TODS they say, or the rings are also, perilimbal rings are also available, and you can have a contact lens. Then the various delivery system like Innovia or the high solution inject printing technology is also available. And the internal platform like intracameral implants, it's already been discussed. They are also available. The only worry to me is it is frequently to be injected and the endothelium may be affected by this. And the ophthalmic micro pumps are also now designed, which are to be implanted in the subconjunctival space, and they are programmable, refillable, and last for 1 month. And then last slide, that this miRNA 124 is a delivery system for the biodegradable nanoparticles, and it is a very, very safe and economical system. So with the incorporation of this with the other anti-glaucoma medication, we might have in future a better drug molecule which can give us a good. So lastly, one single molecule takes at least 15 years to come in the market. So we have to wait, but a lot of them are there in the process. Gene therapy, I will not say. Thank you very much.
Thank you, Dr. Mayuri. That was indeed wonderful, and we have a lot to look forward to. So I'll take the last talk.